Hello, and welcome back to another amazing episode of the Folding Towers podcast. Hello, Jackie.
Hi, David.
What's How you happening? going? I'm doing all right. Doing all right for an old fella.
You're not old, David, by any stretch of the imagination.
We've just had school holidays, and my kids went to bounce, one of those big trampoline parks. My son bounced hard, and he was doing flips and bouncing off the walls and off the floor and off the roof. And the next day, he's limping around the house, groaning, saying, "I'm so sore. Is this what it feels like to get older?"
And what was your reply?
Yeah, kind of, but I felt that way just waking up this morning. That's what I did to deserve my pain.
Yeah, it does get a bit like that, doesn't it, as you get a bit older?
Yeah, life lessons. Yes, it's like getting older but with fewer bills.
Yes.
Yeah, what's been happening with you, Jackie?
Not a lot, just continuing on with life and focusing on the sports things with my children. Sport has ramped up and is all starting, so yeah, just getting ready for that. Yeah,
the children have needs.
Yes, so Mum's Taxi is got the sign out on the front, and off we go.
Well, this is an exciting episode today, Jackie. We have a guest patiently waiting for us whilst we banter on.
We do. He's been very patient.
Yeah, so today's guest is Aubrey Gowing. Welcome to the show, Aubrey.
Hi, folks. Thanks for having me on. It's an absolute pleasure to be with you guys today.
We are excited to be chatting with you about chronic pain and what it is and where manual therapy fits in. And Aubrey is a manual therapist, an educator and international presenter based in Dublin, Ireland. He's the author of 4 books, including Musculoskeletal and Sports Therapy series, and his latest, The Kinesiology Taping Strategies, with a focus on treating overuse injuries, repetitive strain and chronic pain. Aubrey co-hosts HCD Massage School with his sister Alison, delivering massage education for over 40 years. He's also a former 3-term president of the Irish Massage Therapists Association and continues to teach internationally. His current work centers on corrective manual therapy, helping therapists better understand chronic pain and giving them a clear, practical roadmap from what to do in the clinic. This is going to be a great conversation. We're looking forward to chatting with you today.
Yeah, absolutely. It's one of my main areas of interest, I would say, not just in my professional life, but overall. It's been a running thread throughout my life, an interest in the treatment and alleviation of chronic pain, because it's such a big issue for so many people. So really excited to delve into that in this episode.
Excellent. Before we get started, we should mention that, Aubrey, you'll be joining us here in Australia as a masterclass and keynote presenter at the upcoming Massage and Myotherapy Australia 2026 National Conference being held from the 29th to the 31st of May in Geelong. So if you're listening and want to learn more, head to the Massage Myotherapy Australia website. Details are in the show notes to register.
That is only a few weeks away, David.
It is a few weeks away.
I can't wait. I can't wait to meet you in person, Aubrey. I'm so excited for everything that's happening at conference this year. And meeting you is 100% genuinely at the top of my list, and David's list as well, I'm sure.
We'll be seeking you out for a selfie.
Yes.
Absolutely. Absolutely.
Will you be in Aubrey's masterclass, Jackie?
I honestly have no idea what I have signed myself onto, so I don't know. I always forget, because you do it about 2 to 3 months before the actual conference, and then by the time it comes around, you're like, what did I actually book into? I can't remember.
That was hilarious, the last conference we went to, in a class going, what is this? I don't remember it at all.
Yes, yeah. And I think the last one we went to, David, I actually booked in to that about 4 or 5 months before. Like, I booked in really early.
Yes.
And I had no idea what was happening on the day. It was hilarious.
It was a surprise.
It was.
Yeah. We're going to come out swinging with the hard-hitting questions today, Aubrey. So are you prepared for the first and most important question of the day?
Of course.
Who is your favourite superhero and why?
Favorite superhero? Oh, definitely, without a doubt, Spider-Man. From the time I was a small child, I think probably 3 or 4 years old, my older brother was reading comics, and I got a hold of a Spider-Man comic and absolutely loved it. Wanted to be Spider-Man when I was a kid.
Nice.
I can't say why. I don't know. The character just appealed to me.
Yeah, the radiation and being bitten by a spider type.
Yeah, I suppose being bitten by the massage bug later in life, I kind of relate to it now.
Yeah.
Are you just one of those people that goes all in with something? You're either not interested at all or you're all into it. Like it becomes everything.
Absolutely, 100%. I was definitely like that in school. Like my grades in school were kind of A's and B's and then E's and F's. So the subjects that I liked, I always excelled at. And the ones that I didn't like, I could not motivate myself to do anything with. So I would fail miserably on the subjects that I just didn't like. There was no middle ground. There was no passes. There was honors or fails.
I totally relate to that.
About you already.
Well, before we get into the clinical side of things, what first drew you into bodywork in the first place?
Yeah, I think I probably have a somewhat unique story because my parents actually attended their first yoga class when my mom was expecting me. So jokingly, to break the ice at the start of a class, I oftentimes say, I actually started in the wellness industry before I was born. I started in utero. Wow. And my folks loved it so much. My dad went on to study to be a yoga teacher. And we come from a big family. There's myself and 6 other siblings. And when he was studying to be a yoga teacher, he would line us up on a Sunday like little Russian dolls from the oldest down to the youngest. And we would practice yoga postures, breathing exercises, meditation. So literally from the time I was a small child, I was really introduced to the idea of a holistic approach to life. We ate a very healthy diet. Everything was organic, even before that term was really popularized back in the late 70s and early 80s. It was just whole foods. And we really grew up with that concept. And my dad went on to start the first holistic healing center in Dublin in 1986. And all of the family at various stages went through at least basic massage training. So when it was my turn, of course, I went through massage training. Most of the others didn't stick with it, but myself and my sister that now run the college here in Dublin, we absolutely got bitten by the massage bug and we have not stopped since. So it's been a lifelong pursuit for me.
Wow.
Fascinating. Yoga in Australia, that was kind of a hippie thing and didn't really take off until probably the 2000s.
Yeah. I'd even say late 2000s.
Yeah.
Depending on where you live.
Yeah, because I was teaching yoga classes. I trained to be a yoga teacher as well. And what we found was that there was kind of a resistance, particularly in Ireland. Ireland back in the 80s was a very Catholic kind of country, and yoga was seen as almost a threat to that. It was seen as like an Eastern religion and a bit of a cult. Was very much kind of the outskirts of normal society that, most people thought it was something weird and, like I said, quasi-religious. And what turned the tide, weirdly enough, was when Madonna started doing yoga. All of a sudden then everybody wanted to do yoga. That was back when, Madonna was relevant, and younger listeners might go, who?
Well, the bulk of our listeners are over 40. It's steeply the bulk of our listeners are over 40, so I'm sure that yes,
if they don't know who Madonna is, Madonna has a marketing problem.
Yes, that's right. Well, can you walk us through your professional journey and the key influences that have shaped your thinking around manual therapy and chronic pain?
Yeah, sure. Well, obviously, firstly, my parents. When my mom was studying to be a massage therapist, I think I got my first massage when I was maybe about 8 or 9 years old. So again, like introduced to the whole thing as a child, I always find it interesting in our classes, particularly our foundation classes where people have no prior study. And they come in and we ask, who has never had a massage here before? And sometimes you'll have 3 or 4 people in a class putting up their hand. And these are people in their 20s, 30s and 40s. And it's quite surprising. You're kind of going, you signed up to train in massage and you've never had a massage? So again, to me, it just seemed perfectly normal and natural, having had massage as a child, then going into the profession. I would say it might sound a little bit corny, but my sister Alison definitely has been one of the big influences for me, because I started off with relaxation therapies. I started off studying holistic massage. Really liked that, felt the benefits of it. I had a tendency, I think, to do fairly light treatment. You guys have probably noticed this, and I think most therapists are familiar with this. Some therapists will naturally do quite a strong treatment, and some therapists will naturally do quite a light treatment. And I always think if you can do a really effective treatment with a light pressure, that's pretty impressive. Strong pressure, it's easier to affect change, but to be effective and light is quite a hallmark. It's quite a skill. It's somebody really connecting to the work. But my sister was the one who really started to study more widely. She would go and do a course somewhere. She would practice it on me. I'd get interested in the therapy, and then I'd go and study. So she was kind of breaking a lot of new ground in the early stages. And then I think at a certain point, I started to really get into the treatment of chronic pain. I started to have a lot of success with people who are coming in with back pain. It would take me maybe about 6-7 treatments, but I'd see significant changes in people's back pain. And then as I started to study more broadly, and I started to really get into, I suppose, the popular term here in Ireland is sports massage, even though it covers a very broad spectrum. Obviously, you're not just treating sports people. But I noticed when I started to study, particularly with people like James Wisniewski, James would be, I think, quite well known in Australia as well. I found that the time it took to get results dramatically reduced. So all of a sudden I was getting almost elimination of back pain in 3, maybe 4 sessions. So from 6 to 7 sessions down to 3 or 4 sessions. I thought this is a huge improvement. It's a big shift in your focus. And then James always talked about Eric Dalton, because James worked a lot with Eric, studied with Eric, and I went on and took my first workshop with Eric. And again, that added another new dimension where there was much more of a focus on doing soft tissue work, but then going on and doing joint work as well. Not manipulation, like not high velocity thrusts, but just mobilizing and moving joints. And I've really found since then, once I really got into it and got my head around it and really understood that particular approach, which I think takes in a lot of different elements. Like Eric himself came from a Rolfing background, but he also studied a lot of osteopathy and things like that. And all of a sudden, I was getting resolution with my clients' back pain in maybe 1 session, 2 at the most. So I think that's been one of the big evolutions in my practice is as I've learned more, it's a quicker path to success. Now, sometimes when you say that to therapists, they go, yeah, but like if you're treating people in 1 session, is that not a bad business model? You get some people in the kind of healthcare bodywork industry where they nearly want to sign people up. I've heard of not massage therapists, but I won't mention the particular discipline. People that when you go for your first treatment, they sign you up for a direct debit from your bank. They're like, well, you're going to need to come to me every week from now on. I'm like, wow, that's a very business model approach to bodywork. Whereas I've found that if you get great success with somebody, they will send in everybody they know.
Yes.
So it actually makes your clinic busier, even though you're only seeing people maybe once or twice. And then periodically for, maintenance type work, you might have people come in. I still have a client that started coming into me maybe about 15 years ago more, and she comes in once every 6 months. She had a shoulder surgery, didn't work out well, but she says so long as she gets treatment, she has full movement and she has no pain. Over the course of 6 months, she says she always knows when it's time to come back in because she starts to feel shoulder pain creeping back in, and she goes, oh, time to book in for my next session.
That's amazing.
Oh yeah, it's phenomenal. But I genuinely found like these days I only operate I would describe it as operating as a consultant, where we have a lot of graduates now around the country doing the style of work that we practice. And I would always say when people say, can I come into you for a treatment? I'd say, go see one of our graduates first. They're most likely going to be able to resolve it. I'll treat the very complex cases. So we kind of have a network of therapists that will send in more complex cases to me. I'll oftentimes do 1 treatment and then send them back to their therapist with kind of a game plan, what follow-up needs to be done. So it works out really well for the client. It works out well for the therapist as well, because it means they're continuing their learning journey as well, that if they get a tricky case, they see, oh, here's maybe the thing that needs to be done now, the element that I might have overlooked or something like that.
Yeah.
But when I was in full-time clinical practice, my clinic was booked out 6 months ahead. There was literally a 6-month wait list. So doing really fast, successful treatment, fast isn't everything, but I mean, quick to results, really does make you a very, very busy therapist.
Yes.
Which I think seems counterintuitive.
Yeah. Well, many manual therapists, including myself and Jackie, have their own chronic pain stories, and this has often been an inspiration to entering body work for many therapists. So, chronic pain is one of those areas that a lot of therapists do find challenging because it is complex. It often takes years to experience, years of experience to feel confident working in this space, and often even many years into practice, they're still trying to figure out what's going on and what the nuances of chronic pain actually is.
Mm-hmm.
But I don't think this space is necessarily helped by the internet doctors. I mean, often with their radical and evangelical approaches, and often see things with like those special devices where they yank you across the table by your head, and, and those types of things is great for the drama. But yeah, it's not necessarily a personal approach to pain.
And I think a lot of that kind of the internet stuff and the social media, it encourages spectacle.
Yes.
So things have to look, weird, or you know, the stranger the better. It gets more clicks, more likes.
Yes.
Yeah. Yep. There's some really odd stuff being brought to the forefront at the moment, or where like buccal massage at the moment is very popular, taking off, and this will cure all of everything, including syphilis, and make you left-handed and all the rest if you can have your face peeled back over your eyelids. Of
course.
There's some amazing claims.
Oh my gosh.
What is the difference between acute and chronic pain?
Well, I suppose that it's a really good point, because I think chronic pain is where massage therapists are ideally suited to help clients. Because I'd oftentimes say with orthodox medicine, they are superb at emergency medicine. They do amazing work. I think their Achilles heel is really chronic pain problems. We've seen this with the opioid epidemic, that seemed to be the go-to solution. And even still, it doesn't work very well. It wasn't a very successful intervention, apart from having other complications. And I would say that manual therapy really is the key to unlocking most chronic pain conditions. So with acute injuries, usually is what we're talking about when we talk about acute pain, which there's kind of a clarification needed there, because we have acute injury and then acute pain, because the term acute just means pointed, sharp, like a needle, like an acute angle. So normally we use those terms as acute pain is severe, sharp pain, usually neurological pain. And acute injury is when a traumatic event has occurred and there is rupture, there is damage to tissues within the body. So I would say that there is a big difference. I suppose a good way to illustrate the difference between acute conditions and chronic conditions might be to look at two different scenarios, two different things that a client might come in with. I would say, and a good example of a acute injury might be something like an ankle sprain, where the client has literally just rolled their ankle maybe the day before. They've torn some ligaments, there is inflammation, there's swelling, there's redness, there's heat, there's pain, and that injury needs time to heal. There's still things we can do to assist in that process, but the body has to go through its own repair mechanism. So there's not a huge amount that the manual therapist can do. Whereas if we compare that to something like shin splints, I think shin splints is a really good example of a fairly common chronic condition that people will suffer from. Now, I think the key element between these two different things is one has a mechanism of trauma. You've rolled your ankle and you've torn ligaments. The other oftentimes just seems to come out of nowhere. And it might bother you for a little while. It might even then subside, and then it might reoccur. It kind of goes through these phases of flare up and settling down. But the big thing that helps manual therapists to understand how to treat chronic pain, I think, is to understand that with acute injury, the pain is where the problem is. When you roll your ankle and you've torn ligaments, it's painful where the site of injury is, where the trauma has occurred. That is not the case when it comes to chronic pain. Invariably, where you feel the symptom is not where the problem is coming from. So for most people, when we talk about shin splints, again, this is really a vague generic term. It means I have pain between my knee and my ankle. So there's a few different things that will cause shin splints. But in the vast majority of cases that you're going to see in clinic, what you're actually witnessing is a dynamic compartment syndrome. The connective tissue is too confining in the anterior compartment. So when you go to exercise, Muscles, when they're working, the body helps them to work by increasing blood flow to those muscles. As blood flow increases, those muscles will increase in diameter. Anybody who works out will know that sensation of feeling a pump when you've lifted weight. But with shin splints, as the muscle tries to expand, as it becomes suffused with blood, it's got nowhere to go. Its own fascial wrapping is too confining, or maybe the wrapping of the compartment, maybe not the individual muscle. It can be both. And as the muscle then starts to expand, it actually compresses the more delicate structures. So the first thing it will compress is the lymphatics. So now you've reduced the outflow. The body can't get rid of its metabolites from that area, so lactic acid starts to build up. I always say, the clue is in the name. Lactic acid is acidic, so you're going to get this kind of burning sensation down the front of the shin. That is not really a problem with the anterior compartment. It didn't start there. Invariably, what we see is the antagonistic muscle is actually the root cause. So in this case, it's usually posterior tibialis. So when you work the anterior compartment, you can help soften that fascia momentarily. You can help to create a lot of nerve stimulus, and it will feel better for a little while, but it will come back within hours or certainly days. If instead you treat posterior tibialis, you restore normal tissue texture, normal ability to shorten and lengthen, you improve neuromuscular coordination between those two opposing muscles, posterior tibialis and anterior tibialis, and then you'll find anterior tibialis starts to work better. So its fascia starts to glide again, it rehydrates, and you don't get the recurring symptoms. So the thing to remember with chronic pain is where it hurts is not where the problem is. If you're treating where it hurts, the problem is going to continue. If you look at the antagonistic tissue, and I mean, if you're not familiar, there's very straightforward patterns. This is what we do in all of our workshops and all of our seminars. We talk about common patterns of dysfunction, how to test for them, how to identify them, and how to treat them. And it really provides you with a concise roadmap for treating any chronic condition. But as a simple thing, as a start off, when a client comes in, they say, oh, I have pain in my upper back, between my shoulder blades. You're thinking, okay, rhomboids. Look at the action of the rhomboids. They're shoulder retractors. They pull the shoulder blades back. Now think, what muscle does the opposite? That's the muscle to treat first. So I would say when people have rhomboid issue, I actually treat their pec major, their pec minor, their deltoid, and their bicep. Because those are the muscles at the front pulling those shoulders forward and down. The top edge comes down, the outside, the acromion. So it creates kind of a rotation, a drag forwards, and really stresses out. It overstretches the rhomboids. The problem is the sensation. People feel, they'll say, oh, I'm really tight in this area. And yet they've got rounded shoulders. So like if your rhomboids were tight, you would have the opposite. Your shoulder blades would be pinned back. You never see that in clinic. So you know those muscles are not tight. But the sensation, I use a different term. I'd say those muscles are taut. So we would say, imagine a guitar string that you are winding to produce progressively higher and higher notes each time you strum it. That string is getting more and more taut. It's not getting shorter. Your rhomboids are like the guitar string. The more the shoulder blades start to slide around, the more you get that rounded shoulder posture, the more overstretched and taut the fibers become. It compresses the capillary bed, compresses the lymphatics. You now have a reduced fluid dynamic. As fascia dehydrates, it starts to stick. So over time, you get literally stuck in that posture. But the buildup of metabolites irritates the nerve endings, and that's why you experience pain, and it feels like tightness. So this is where we have to really be careful about language, because if somebody says my muscle is tight, what do you think you're going to do as an intervention? What's the first thing most people are going to do? They're going to stretch, right? Yeah. So if you stretch those weak rhomboids, they're not going to get better. They're already weak. You're just winding the guitar string tighter. Instead, what you need to do is create some slack, some space. And how you're going to do that is by getting those shoulder blades back. So this is why we need to treat the front of the body first. It's a common thread throughout the body. You will have more success if you treat tight muscles before weak muscles. Again, a lot of your audience probably know this already, but do we always implement it in clinic? Are we tempted to treat where the client feels they need the work, treat where the pain is? That will be less successful. You got to treat the tight muscles before the weak muscles can actually respond properly in a more lasting way to a manual intervention.
I would say in Australia we have a big problem with this. I don't know how it is in other states, but definitely in South Australia there is at least a small problem with this, where I even was talking to a friend today and she said one of her massage therapists that she sees only works on the back of the body. Never has her supine. And she said she does a lot for her, but she does wonder. Yeah. And you've really brought it to the front. You have to work, the opposite muscle, and everyone's complaining about their back, aren't they? So, yeah. That is so interesting.
I was literally just over in Spain. I got back yesterday. I was doing a yoga retreat over there, and there was a girl on the course from Norway, and she said, "Oh yeah, I've got terrible back pain. I've had back pain for years. I do an office job, yada, yada, yada." This was a really, really nice yoga retreat place where you got a massage every day. So they did really healthy food. They prepared all the food locally. We did morning yoga, afternoon yoga, evening yoga. We did some meditation. They had hot saunas and stuff like that. It was a really beautiful, beautiful place. But I wanted to wait until the end of the retreat to see, did it change this girl's back pain? And it didn't. She said she felt great. There's benefits from relaxation and all the rest, but her back pain was still there. So I always check with the host. I said, you guys are massage therapists here. I don't want to be stepping on anybody's toes, but is it okay with you if I do a little bit of treatment for this lady? And they were like, absolutely. Because I'd said to them before, it comes up in conversation that you teach therapies and all the rest. So they're like, oh, absolutely, go for it. Completely, no problem with that. So literally just on one of the lilos by the pool, I did some work on this lady, and we started on the abdomen, because I always think back pain usually comes from hip flexor dysfunction. Sometimes they're tight, sometimes they're weak, more often tight. And that usually then pulls on the bones. I always say it sounds so elementary, but we forget this. Muscles pull bones. If joints are out of position, there's muscle imbalance. So we start this girl face up. We're working on the abdomen. And like most people, she's like, oh, it's my back. And I'm like, yeah, I know it's your back. We'll get there. So we work down through the abdominal musculature, down through the viscera, and down onto her psoas. Obviously checked beforehand, make sure she didn't have any kind of inflammatory digestive conditions. We're, working with care and attention, so you're not disrupting any blood vessels or anything like that, because those are things that you do need to check for before you do this work. There are some safety precautions, and we always talk about these in class. But we worked on her iliacus and her psoas. Then I turned her face down, and we did a pelvic torsion correction, which we'll be doing actually in our pre-conference workshop in Geelong in a couple of weeks. And I would say I probably worked on her for 25 minutes, tops. And she got off the table and she was like, oh my God, where's my back pain? I said, walk around, do a squat. What movement usually bothers you? And she said, well, usually if I bend forwards, like if I hip hinge, she said, I'll get that kind of sharp pain. She bends forward. She's like, I've no back pain. And for the rest of the day, she was just going, I can't believe I have no back pain. I still have no pain. And she woke up the next day and she goes, I still have no back pain. My back pain is gone. Oh my God, this is amazing. And that is the thing, that if you are just treating the back, it's going to feel lovely. It's going to feel nice. It's going to increase blood flow. It's going to stimulate nerves. It's going to cause neural gating mechanisms. It's going to help to decrease our sensation of pain. But the underlying cause is still there. So the same cause is going to create the same outcome. If you don't treat the cause, you will continue to get the same outcome. So the idea of just treating people's backs, I'd be like, yeah, that's going to be nice, but it's not going to resolve the issue. And the key thing should be, you said she goes to this therapist regularly. You're going, well, if they were doing a successful job, you might choose to go regularly because massage feels wonderful, but would you need it as much? So I do think that this is a key thing for people to understand, to treat tight muscles before treating weak ones. Certainly if you want successful outcomes, if you want lasting results.
I think where a lot of therapists fall over is they're either disempowered through the clinics that they work in, where just do what the client wants and rebook them at the end, because that's the business model, or they fall down with communication. And your example of rhomboids that have that painful burning sensation, and then trying to explain to the client, well, actually, where it is, it ain't. And we need to do the things before we get to where you feel the problem area is. And that's one of the signs of a mature therapist, is having those communication skills to confidently say, well, I've assessed you. This is where we need to work. We will get to where you think it is. We will get there. It's okay. Yeah, but we need to do these ones first. It's if you want longer lasting relief.
You've got to have the conversation to get buy-in from the client, for them to understand why you're doing things. Why aren't you rubbing my back? My back is sore. So I do think that communication skills are key. I do think that knowing your anatomy is quite important as well. I know for a lot of therapists, it's a bit of a drudge, or it's an area that they're maybe terrified of when they start training initially, because anatomy is complex. It takes a long time to master. But there's so much technology out there to help us now. You can use apps, and you can literally just review a muscle a week. Take your time. You have all the time in the world. You don't need to know all the anatomy straight away. I certainly didn't when I was starting. I would say now I have a pretty good handle on it. But from the get-go, I wasn't as clued in. And even though I would have learned more as I went along, it probably took maybe the first 10 years of my career before I really felt I knew my anatomy quite well. And then it continues to develop over time. You go into greater and greater depth. But understanding the anatomy and being able to explain it to the client, I think really, really helps. And something we always really try to emphasize is a really skilled therapist who understands their subject should be able to move easily between the terminology and jargon of anatomy and massage therapy and simple everyday language. Because a lot of people, when they talk to their doctor or their healthcare provider, a lot of the information goes over their head because there's too much terminology and they feel maybe even a little intimidated. I think if a massage therapist only uses layman's terms, they don't sound as knowledgeable. They don't sound like as much of a professional. If they only use terminology, the client is lost. Yes. There's no real communication. But I think you need to have simple explanations that the client can connect with and understand, sprinkled with a little bit of terminology to demonstrate expertise and again increase buy-in, because if the client feels that you're a more knowledgeable therapist, they're going to feel safer in your hands, they're going to trust you more, they're going to relax more, and they're going to get more benefit from the treatment. So I do think it's a quite unique skill to be able to go back and forth between the two of those.
Yeah.
Communicating with clients is definitely one of those things that I think massage therapists and people generally that work with the public can often feel really quite scared about or nervous about. And really, it's something we could probably spend about 3 or 4 hours talking about as well, because it can be hard to navigate some of those conversations and get the client to understand, like you said, hey, we actually shouldn't really just work on your back. Let's work on everything else that's happening in the body as well.
Yeah.
But it's also one of those things. It's also one of those things in the peer-reviewed literature is that therapists or health professionals that have good rapport with their clients have better outcomes.
Yes.
Now, the skill of the therapist, other than the communication, isn't mentioned there. So the client that trusts you will have a better outcome.
Yes.
Yeah. It's a very interesting area of study, like how many things feed into successful outcomes. And the whole interaction from start to finish, all of it is important. Yeah. Literally, they say one of the biggest things that influences a client's expectation is if they're in the waiting room and they see the previous client coming out and they're smiling and they have an open posture and there's a good rapport between them and the therapist, immediately that new client sitting in the waiting room feels set up for success.
Yes.
So those little things can make a big difference. And they'd say also not having pathology posters in your treatment room. Anatomy is fine, but you don't want to be putting forward the idea that you're catastrophizing, that this is a terrible thing that you have. Right. That it's always we'll see what we can do. This should help, and when we do this should improve things as well. Never overpromise, but at the same time, you always have that kind of open to what might happen. This positive expectation, nearly of. I get complex things. One of the things I've found quite interesting to deal with is vertigo, because there is a mechanical element that massage therapy can help, and then there's stuff in the inner ear that massage isn't going to do a huge amount for. So when I get clients coming in with vertigo or even tinnitus, very similar kind of conditions in some ways, even though the symptoms are quite different, I'll always say to them, I've had some good results with this, but not always. Sometimes it's not about the soft tissues. Sometimes it's to do with what's going on in the inner ear or the nerve, the auditory nerve or something like that. And I'd always say, so at a minimum, worst case scenario, what I'd expect is a really good improvement in how your neck is going to feel, because we're going to do a lot of work on your neck. I don't know whether or not it's going to affect your vertigo symptoms, but let's see. Sometimes it does, sometimes it doesn't. I don't want to overpromise, but at the very least, you're going to feel like your neck is great. So it kind of sets them going, okay, so there's going to be a good outcome. I'm not going to be overly disappointed if it doesn't work, because I've been told There are complicating factors. There are other things that may influence whether or not the condition clears. So you've set a realistic expectation, but it's still positive. I think that kind of communication is important.
Could not agree more. That is so, so true.
So how does the treatment approach change when treating acute versus chronic pain?
Oh, so I suppose with acute conditions, we don't tend to see that many of them in massage clinic, because most people, if they've had a traumatic incident, they'll usually go to their doctor, they'll go to the hospital. But sometimes you do. I had a client, actually, we were just talking about a sprained ankle. I had a client a few years back, and she was booked in for a session, but that morning she got out of the shower and the phone rang, and she ran to get her phone with wet feet on a tile floor, and she slid across the floor and whacked her foot off the countertop, or off the counter, and she sprained her ankle. She came in limping in. And I said, okay, we're going to be limited in what we can do because this is only like a couple of hours old. But I think the best thing that the therapist can do in the acute traumatic phase is say to the client about, there's a process they can go through called the ladder of recovery. And it really speeds up healing and repair. With that girl, we were able to work above the injury. We did some taping for her. She was walking pretty well, actually, at the end of the treatment, but she still obviously had some pain. The tissues had to heal. Very funny. She was going to a music festival the weekend, and she's like, so can I go? Like, I'm her dad, and she's asking permission. And I'm like, well, my professional opinion is going to be no, but I know you're going to go anyway. She goes, yeah, I'm going to go anyway. I said, it's going to make it worse. That's your choice. If you have been looking forward to this music festival and you're determined you're going to go,
it's good for the soul.
My professional advice is you should not go, because I know you're going to make it worse. But she went and she recovered. It was just a slightly slower process.
Yeah.
But I've had that experience myself where I do quite a bit of adventure sports. Snowboarding would be a big one for me. And I've sprained my right ankle, I would say, about 5 times. And the first time I did it, I was late teens, early 20s. And I didn't know much about rehab. And I would say I had that typical weak ankle for about 18 months. I'd step on an uneven surface and it would go again, and you'd be limping around for 5 or 10 minutes. But each time I sprained my ankle, I actually knew more and was able to rehab it better. So the next time, I think I was up and walking again in about 3 weeks. The time after that, it was about 2 or 3 days. The last time I sprained my ankle, and I haven't done it in about 15 years because I have a protocol now for avoiding that, strengthening up the muscles so you don't actually roll your ankle, that I would say I was able to walk pain-free the next day. And I've sprained that ankle enough to know when it's an actual tear. It wasn't just like you tweaked it or something like that. It was a pretty bad tear. So we'd always say in the acute stage of injury, you follow the ladder of recovery. And the first step on that ladder is pain-free movement. So for me, that meant just little wiggles of my foot, because movement helps to pump the lymphatics. It helps to clear away some of the swelling, but it also helps to prevent too much scar tissue from forming. That movement helps to align collagen fibers in a functional direction, the direction of load. So literally within minutes, I was wiggling my foot. Within a few hours, I was able to move my foot much more. And then by that evening, I was able to fully move my foot without pain. So pain in that scenario is actually your friend, because it tells you when you're doing too much. If you do too much, you re-injure the area, you slow the process down. But the first step on the ladder is pain-free movement. I had pain-free movement by the end of the day. So the second rung on the ladder is pain-free stretching. You start to gently stretch the muscles crossing that joint. Once you've got full stretch pain-free, the third rung on the ladder is strength. So this starts off again super gentle. It's all got to be pain-free, so you're not running the risk of re-injury. When you then load those tissues progressively, then the tissues strengthen up. And when you've got full strength pain-free, you're rehabbed. You can go back to your day-to-day activity or back to your sport. So in the acute stage of injury, that's really what I tend to focus on, is in educating the client not to ice the area. Ice actually reduces healing. I actually think it's really, really interesting. The guy who coined the term RICE, rest, ice, compress, and elevate, that was, I had his name and it just popped out of my head. Gabe Merkin. So Gabe coined this term back in, I think, 1978. And in 2015, I've been saying this since about 2020. I was saying, I think ice is counterproductive. And there was very little evidence at that time. But in 2015, Gabe Merkin himself came out and said, I'm recanting my statement. ice is not appropriate. It slows down healing. He actually said anything that interferes with inflammation is essential for healing. It's an important part. It's the first stage of repair. He said anything that interferes with the inflammatory process is going to reduce the quality of healing, which was pretty broad because he included things like painkillers and stuff like that. You shouldn't actually need painkillers. Or if you do, very, very mild ones. But again, that's outside our scope. You're going to be going to a medical professional for painkillers. But if you are using pain as a guide to go through that ladder of recovery, you actually don't have much pain. But you detect the edge where you're about to encounter pain, and that's what keeps you safe. So I thought it was really, really interesting that Gabe said, don't use ice. It congests the lymphatics, it slows the repair, and they actually said that the cells that are providing the repair go into a state of suspended animation when you ice them. So yes, the idea that you're getting less cell death, less cell necrosis from oxygen starvation in the site, that is a benefit, but it's countered by the reduction in the function of the repair cells. So they said overall, it's like you keep pressing pause, you're dragging out the duration. The likelihood of re-injury or poor quality healing during that dragging out of the repair phase means poorer quality healing and a longer time to fully rehab. So it's a double negative, I would say, anyway, getting slightly off topic. Yeah. In the other scenario, if the person has like acute pain, but it's not injury, you get a lot this time of year. People are out in the garden for the first time in a while, and they get a flare-up of back pain, and they'll oftentimes call or email, and they'll say, "Oh, can I get into you tomorrow? My back is killing me." And the advice I give them is get into a hot bath. We're not worried about bleeding. There isn't trauma. This is just a sudden flare-up of acute pain. Get into a hot bath for about 5 minutes. The heat will increase blood flow and soften collagen and reduce perception of pain. Get out of the bath after 5 minutes and stretch. In particular for low back pain, I recommend stretching your hip flexors. So they've usually seen this because they oftentimes have a pre-existing condition, so they know how to do their hip flexors, or we'll send them a link to one of our videos on YouTube or something like that. So you heat up for about 5 minutes, you get out and stretch, and then you get back in for another 5 minutes, get out and stretch, get in a third time, and each time when you're getting out and stretching, you notice you can stretch more with less pain. And the combined effect is far greater than either one on their own. Because if you just have the hot pack or you have a hot bath, it softens everything up, but then it cools back and goes to the way it was. So the effect is lost once the heat is lost. If you try and stretch in that scenario where you've got pretty acute pain, it's too sore. So you're kind of in this bind. If you combine the two, the heat allows you to stretch more, so you're making use of that window of opportunity while the tissue is warm and more pliable and you've less pain to actually correct the problem. And invariably, once clients do that, they call the next day and say, "Yeah, I'll be in for my regular appointment. The back has settled down. I don't need to come in tomorrow." So those are the two pieces of advice that I give. In acute injury, the ladder of recovery. In acute pain, where there is some trauma, I would say heat and stretch.
Okay, guys, whoever is listening, all of you wonderful people, if you haven't noticed already, you must do some classes with Aubrey. You must. This has been a masterclass. We're not even done yet, and this has been a masterclass. There's so many amazing takeaways.
I think that's a nice segue to mention, Jackie, that whilst Aubrey is in Australia for the Massage Myotherapy Australia conference, he's doing some post-conference masterclasses across Melbourne, Brisbane and Hobart over June.
Yes.
So if you can't make it to conference in Geelong, you've got 3 other opportunities to get on board.
Yeah, because the pre-conference workshop and the classes that I'm doing at the conference, they booked out ages ago. I was talking to some of the guys in MMA. Shout out to them, by the way, for inviting me over. This is my 3rd time over to Australia. So absolutely delighted. I have huge respect for the guys in MMA. They do incredible work. And the amount of effort they put into these conferences is just phenomenal. So really encourage people to go, even if you can't make my classes, because they booked out ages ago. But yeah, we've got a bit of a tour coming up where we're going to do 3 post-conference seminars. Nice little 2-day seminars. I think they're generally on Sunday and Monday, because I think for a lot of massage therapists, I presume Australia is the same as most of the world. Saturday's a busy day.
Yes.
And we're doing different subjects as well. So it's not the same class in each place, but it's very much going to be following the same approach, the kind of thing that we've talked about of identifying patterns of dysfunction, assessing them, treating tight muscles before weak. I would also say one of our other core principles is working from superficial to deep and doing pain-free deep tissue. So we tend to talk about intensity rather than pain, and we would say treatment needs to have a certain amount of intensity. We're always trying to strike the balance of strong enough to be effective, but light enough to be pain-free. Because a huge amount of the benefits that we see in manual therapy is actually through the nervous system. We think we're massaging muscles, but we're talking to the brain. We're really communicating through the nervous system. And it's the nervous system that is going to govern those kind of tension levels or weakness in other muscles. I think that's a missing other side of the coin. A lot of massage therapists focus on treating tight muscles, and they don't realize the importance of also treating those weak muscles as well, and how to best treat them and how to stimulate tone. So it's not just about loosening the muscles that are tight, but actually tonifying the muscles that are weak. So we go through those kind of overarching concepts in every single workshop that we do, regardless of what the subject is or what body part we're working on.
Let's come back to the mechanisms of chronic pain. Through, I guess it's probably common across many clinics, is that you have the common client of the office worker with, say, upper back or lower back pain from sitting from too long, or I guess similarly a truck driver, some delivery driver who's on their butt all day. You then get the tradies who've been bent over all day, working with vibration tools or impact, carrying heavy loads in odd positions. And then the one which is gratifying and head scratching and stimulating are the people who are coming in with complex chronic problems. Maybe there's some trauma related, emotional trauma as well as physical trauma, say a whiplash injury from a car accident, or those who've been diagnosed with a condition like a fibromyalgia or complex regional pain syndrome. What are the mechanisms? These are all different things. We don't have a month to study in this episode. What are the mechanisms behind chronic pain becoming chronic?
Well, I suppose if you can write that list down, we'll deal with them briefly one by one, because once I get into it on one element, I know I'm going to forget about the other ones. But I would say there is a few different mechanisms. Taking, I suppose, the kind of overuse repetitive strain one as a very obvious one, because that's very common across a lot of the different things that you mentioned. I would say that it oftentimes starts out as habituation in the nervous system. Mm-hmm. So if you're sitting a lot, the muscles in the front of the hip get short and tight, the muscles in the back get overstretched and weak. And the posture control center in the brainstem, it's called the pontomedullary reticular formation. You can see why we use a lot of abbreviations. PMRF is usually what they'll say for that, because it's a lot easier to say than pontomedullary reticular formation. The brain gets slightly, I won't say confused, it's that the scales are off. You know, the example I oftentimes give is the person who wants to lose a couple of kilos, and they just put the bathroom scales to -3, and they go, oh, there you go, I've lost 3 kilos. So there's a miscalibration, I think, that occurs in the nervous system through habituation. But then there's the local tissue change as well. Because like I said, the layers of connective tissue within the muscle, the fascial layers, or epimysium or perimysium or endomysium, is not really 3 layers. Each one of them has multiple layers. I'd really recommend people look at, there's a video series by Dr. Jean-Claude Guimbarteau on YouTube. It's free. The first one is Strolling Under the Skin. And he is a plastic surgeon, and he inserts cameras under the skin. He shows the fascia in a living person and how it's moving, which is very different to cadaver work. Cadavers are dead and dry, and the nervous system ain't doing nothing no more. So cadavers are interesting, but it's not the same as working living tissue. In this Strolling Under the Skin, he shows how these layers within the muscle have to be able to slide across each other. So I oftentimes use the analogy of like a telescope, where it collapses down on itself into segments. That's like the multiple layers, say, in the outer wrapping of the muscle. If you're not moving very much, those layers start to become dehydrated and stick together. Now, if that's in a short, tight muscle, like in the front of your hip, they get stuck in a shortened position. If it's in a weak muscle, they get stuck in a long position. And you can get variations in between. There is a spectrum. So once that tissue starts to stick, the muscle cannot move as well. That then starts to irritate the nervous system and cause guarding. And if there's sufficient guarding, then it starts to mildly compress on nerves. Now, not to the extent that will cause immediate pain, but what it will do is reduce the fluid dynamic within the nerve, what's called the axioplasmic flow. We can think of it as like the internal circulation, because cells in nerves are living cells like every other cell. They need oxygen and nutrients, and they're going to produce carbon dioxide and waste. And if that fluid dynamic is reduced, the metabolites start to accumulate. In our industry, a lot of people use the term toxins. I don't like the term toxins because it's so easy to debunk. I think metabolite is a much more accurate descriptor. Metabolites will accumulate and start to irritate and sensitize that nerve. So now mild stimulus can be perceived as strong stimulus. What might have been a little bit of discomfort now becomes pain. So it kind of sensitizes the whole nervous system. And I think one of the things we do as massage therapists is calm the nervous system. We get rid of some of that sensitization. That's one of the mechanisms that we help to reduce pain. But then, because we're not moving properly, bones start to get pulled on. And then the seal around synovial joints, the synovial membrane, that kind of joint capsule would be the outer part, and then there's an inner part, and then there's a synovial membrane. They start to stick together because they dehydrate. So now you get locking up of joints. So what I think starts off as a nervous system issue becomes a muscular issue and eventually a joint issue. And this is where these things tend to just snowball. It compounds over time and tends to get worse to the point that it produces significant symptoms. Now, on the idea of overuse, I think once people get soreness in tendons in particular, but we see the same thing in ligaments as joints move out of their ideal position. Anytime people have tendon pain, what do they call it? What do you think? Tendonitis, right?
Yes.
Yeah. So everybody will say, oh, I've got tendonitis. So they'll go and they'll maybe be prescribed anti-inflammatories for the inflammation they don't have. I would say that there is nearly 3 primary dysfunctions that we see in muscles and tendons. Tendons, we'll take the example of here. So you have when trauma has occurred and there's tearing, then there's inflammatory processes. That is actually tendonitis. But we also have pain in tendons that have not been recently torn. You might have, like you said, old scar tissue from something like a whiplash injury. So you might have old scar tissue, but it's not inflamed. So that's a different term. That's tendinosis and requires a different approach. You've got to resolve the scar tissue, which manual therapy can do very successfully and very quickly. So if you have tendinosis, you need treatment that addresses the actual scar tissue and resolve it, normalize the tissue texture. But then the mildest form, not in terms of symptoms, but the easiest to correct is what's called simple tendon pain. There's no scarring, there's no tearing, there's no inflammation. When you say that to clients, they go, no, but it's really sore. And I say, no, simple tendon pain isn't about how sore it is. It means there's no other complicating or compounding factors. That tendon is sore because there's too much stress on it. If we normalize the tissue texture and the function of the muscle, as soon as pressure comes off that tendon, the pain goes away. Nothing else needs to be done. And in most overuse conditions, people have simple tendon pain. Or, like I said, if it's got to the stage of joints being compromised, you have simple ligament pain. Like the lady that I was treating in Spain. Her SI ligaments were quite painful to the touch. This is what I actually use as my go-to criteria for when has the torsion resolved, the twist in their pelvis, when is it back to normal? Because as soon as those bones are in their neutral position, those ligaments are no longer painful to palpation. And here's where I'd argue against the people who say, oh, any kind of manipulation of the pelvis, there's almost no movement at the SI joint. And we go, yeah, there's almost no movement. But there is sensitization of those ligaments. And after you get the bones back in the right place, there is no sensitization because the amount of movement at the joint is tiny. But the ligaments are not in that center of rotation. They're out from it. So it's like the difference between when you look at the hands of a clock moving, look how big the movement is between minutes or seconds. Compare that to how much movement takes place at the fulcrum, in the center of the clock. How much movement takes place there? It's tiny. But when you magnify that movement by the length of the clock hand, you'll notice the movement becomes magnified. It's more observable. It's a bigger motion. Same with the SI joints. The movement at the joint is tiny, but out along at the edge of the bone where the ligament is, the movement is increased. The degree of motion is increased. And so when pressure comes off those ligaments, the pain resolves instantly. People can have this. Actually, we had this experience last time I was over in Australia. I was doing a demonstration of this. The Massage and Myotherapy conference was in New Zealand, and we had a couple of different volunteers come up. They had very, very painful low backs. They were saying like 7 out of 10 back pain. And when we would palpate these ligaments, they were sharp. They were really, really painful. By the end of the demonstration, the muscle texture is normalized. The bones are back in their neutral position. Those people had zero pain. So you press those ligaments and they're no longer painful. So I think that's really something to bear in mind with those kind of overuse conditions, that oftentimes it's just about bringing muscles back to their normal function, normalizing what we would describe as tissue texture, and then getting joints back into the right position. Now, obviously, you have to bear in mind scope of practice. If you haven't done any training in any kind of joint work, I'm not recommending you do that without training. Always stay within your scope of practice. If you do some of our workshops, you'll have some of those tools to take home with you for clinic for the next day.
Oh my gosh.
So, what are some of the tips for manual therapists to maximize their success rates?
That's a good one. So I would say, again, we talk about this at the start of pretty much every seminar. We talk about the overarching concepts. And I think if you follow those, you will get quicker and better results with less pain. Oh, the other thing about this kind of pain-free approach to deep tissue as well, we talk about, rather than just pressure, we talk about the 4 elements that influence intensity. There's area, angle, pressure, and pace. And I think far too often therapists, to try and meet the needs of their client, they go overly forceful. They start straining their hands, hurting their shoulders, stressing their thumbs in particular. And I'd always say that if you adjust those 4 elements of area, angle, pressure, and pace, you can work quite intensely, but not so much that you create pain, that those tissues stay relaxed. So the overarching principles, one of them is keep the treatment pain-free. Good news for the client, good news for the therapist. You don't have to go so forceful. I'd always say at the end of a busy therapy day, I'm not physically tired, I'm mentally tired.
Yes.
Because it takes so much concentration and focus moment to moment with every single client, every single minute of the therapy day. You're gauging the tissue responses literally second by second and adapting your area, angle, pressure, and pace. So if you do those things, you have great longevity in your career, but you also have more successful treatment outcomes. So I would say that being aware of those elements, thinking about intensity, treating tight muscles before weak, even if you're not quite sure what the client has, think about the area that they're complaining of having pain in and think, what are the antagonistic muscles? Treat them first. If you work from superficial to deep, you never have to be overly forceful because each layer softens as you work it. Leon Chaito, I'm sure, is quite well known in Australia as much as he was here in Europe. Leon is one of our most prolific authors. Leon passed away, unfortunately, about 4 or 5 years ago now. But I always like picking up little turns of phrase from people like Leon, the giants of our industry. Leon used to say, relaxed tissue is transparent to palpation. That means if you work, say, the first and second layer of muscle and you soften and relax it, you can now access the third layer. You can feel through those first and second layers to palpate, to evaluate, but also, and if you take that layer by layer approach, you can work all the way down to the deepest 6th layer musculature. You can work all the way down to joints. You can move joints without much effort, certainly without any pain. I would say the opposite is also true. This is my take on Leon's relaxed tissue is transparent to palpation. Tense tissue becomes opaque to palpation. If you're hurting your client, they're going to tense up. It's a natural guarding response. That tension blurs the tissue underneath. You cannot feel through it. The more force you use, the more they're going to resist. And so we get into this downward spiral that doesn't serve the therapist or the client. You're hurting your client unnecessarily, and you're having to apply a lot of brute force, which is going to damage you as a therapist. In the early stages, while you're learning this, I would say a good thing to bear in mind is if your hands get tired doing a technique, what you should treat that as is an indicator that you are being impatient. You're trying to go too deep, too soon.
Yes.
The body is not ready for it. So people will say, oh, I'm finding this technique kind of tiring on my hand. I'm like, calm down. If you take your time, the body will let you in. You should be an invited guest into the deeper tissues, not somebody barging their way through a barred door. So if you calm the nervous system, you can access those deep tissues incredibly successfully. So I think just those couple of nuggets, if you simply apply that to your clinic work, it will provide you a little bit of a roadmap. But then in our training courses, we talk an awful lot about common patterns of dysfunction. We actually did a short video series called The Essential 8, where we looked at the 8 most commonly dysfunctional muscles in the body, one in each area. And we focused on what kind of things do they cause? Because not only are these the most predictably dysfunctional, but they cause the most issues. So we were talking about shin splints earlier. And I would say in our Essential 8 series, the muscle that I think is most important to work for all conditions below the knee is posterior tibialis. A dysfunctional posterior tibialis will cause not only shin splints, but also weakness in the anterior and lateral compartments, making you more prone to ankle sprains. It will also cause pain in the arch of the foot, which is often misdiagnosed as plantar fasciitis. Plantar fasciitis doesn't occur in the arch. So this is an example of that simple tendon pain, where the attachment, and it's a really broad attachment, posterior tibialis attaches to almost all of the tarsals. It has a attachment across the arch that gets painful when the muscle is not functioning properly. It can also mimic, because it drops the metatarsal heads, generally the second and third metatarsal heads, it can mimic things like Morton's neuroma. So it can cause a whole gamut of things. It can lock up the talus, so you now lose hinge motion as well. You can't walk properly, so it's going to increase the tendency to bunions, callousing. It's going to cause you to twist your lower leg in order to walk more efficiently, so it's going to contribute to knee pain. So there is a huge spectrum of problems that can be resolved simply by normalizing tissue texture in posterior tibialis. So that Essential 8 series gives people a very simple roadmap of, look, if you only had one muscle you could work in each area of the body, which one would it be? Which one is going to create the greatest results for the widest variety of clients? So that's a nice little roadmap. That's a really good thing. We talk about that then in each of the seminars as well. So in each body part that we start on, we go, this is kind of the key muscle. This is the one that causes a lot of issues. This is how we're going to treat it. This is how we're going to assess it as well. Because, sometimes people don't have the common patterns, but 95% of your clients are going to fall into that common overuse type pattern.
Yeah.
Dare I ask which muscle it is for the back?
Sure. Which part of the back?
Well,
so I would say
upper back.
For the back, I would say there's actually 2 different muscles. For the low back, particularly psoas. If it's more sacral, then it's more iliacus. And if it's more through the spine, particularly in the thoracic area, it's multifidus.
Oh, interesting.
Particularly if it's quite localized, because multifidus governs motion between vertebral segments. So unlike your erector spinae, the big superficial muscles, they do what's called gross motor movement. They do the big, powerful movements. But multifidus is really, really interesting because it runs the length of your spine. But when you look at its actual fiber arrangement, it doesn't go the length of the spine the way the erectors do. It goes from the spinous process of one vertebrae to the transverse process of the vertebrae below, or sometimes 2 vertebrae below. Sometimes it bridges over 3, but most places it's 2. So what it does is it controls motion. It's the fine tuner between individual pairs of bones in the spine. So when it gets dysfunctional, it can start to either compress, you'll get side bending, or more often you'll get side bending and rotation. So you'll get like scoliotic type patterns. And some scoliosis, I'm quite familiar with this because I get a little bit of this myself from years of wakeboarding and twisting my body the opposite way to my lower body. I have what's called a 4-curve rotoscoliosis. Now, when you have a 2-curve scoliosis, that's the people that it's really very pronounced. You see the scoliotic pattern quite clearly. When it's a 4-curve rotoscoliosis, they're very tight curves, and the person actually looks like they've got quite a straight back, but it curves in odd places. So my sister oftentimes says, it looks like my spine is in backwards because it's flat like thoracics, and then it curves at the lower back, and then it curves in. So it follows normal curves in some places, but then in other areas, it goes in where you'd expect it to go out and goes out where you expect it to come in.
Wow.
But it looks quite straight. And when you palpate in those areas, this really helps to demystify things. I always say palpation is the gold standard of assessment, because when you palpate along multifidus, where there is dysfunction, you'll feel these little fibrotic knots, not parallel to the spine, but perpendicular. And so that indicates to you where multifidus is dysfunctional and affecting movement in that spinal segment. So it's a huge one. We actually did a a stretching series as well to match the Essential 8. This one is free on YouTube. It's called the Essential 8 Stretches. And we put it out, and literally I think that evening or the next day, there's a lady who's done a lot of training with us in the UK, and she commented straight away. She goes, that's incredible timing. I've had this back pain for just about the last 2 or 3 weeks, and it's getting progressively worse. And I did the multifidus stretch last night and this morning, and my pain is gone. So it's a really, really important muscle. So because the back is kind of complex, we can simplify it a lot, but it's kind of complex. There can be a few different muscles. It's not really one. It does depend on the region.
Yeah.
Well, I wasn't expecting you to say the multifidus. So there you go.
Yeah. Not the common culprit, because I think, again, as massage therapists, one of the things that we would define, like we do 3 levels of qualification here in Ireland for sports massage. We do kind of like a foundation level, then we do an intermediate and an advanced. To get to the advanced, it's like a 3-year program. But you get a qualification at each level. So sometimes people just do foundation and they'll go and work. When people ask, what's the difference between the foundation versus the intermediate level and the advanced? I would say that really you're working progressively deeper into the body. So for a lot of the therapists that are out there and you've done, good foundation training, don't be surprised if some of this sounds very new or very alien, because at the early stages, you're working kind of first, second, maybe third, generally first, second levels of musculature. Then in our intermediate, you kind of learn to work those third and fourth layers of muscle, sometimes even down to fifth. At the more advanced level, then you're working the very deep muscles, those kind of fourth, fifth, and sixth layer musculatures, but then also starting to do joint work. And that is the deepest structure, So you get all the way down from the superficial tissues right down to the very deepest. And then, of course, we do some nerve work as well in the advanced, which we'll be doing a bit of in Australia. We're going to do some treating trapped nerves, where we look at the common sites where nerves become progressively compressed in kind of a multiple crush phenomenon, but also how to get nerves gliding again. That is a absolute game changer for a lot of people. If your soft tissue interventions aren't resolving your client's pain, getting nerves gliding will often be that magic bullet that really clears up that last bit of pain. Because here's a little factoid. Some of you might have heard this before, maybe not. Nerves don't stretch.
No, they do not.
To glide. Yeah. So when they get tethered and they get adhered, they get stuck within the soft tissues, they get pulled and yanked around the place, and not surprisingly get sensitized. Yes. But when you treat the key tissues, the common sites for those nerves to get compressed and compromised, when you treat those, you remove the cause, and then you get the nerve gliding again. Then I've had people come in like they've got elbow pain, and it's not really tennis elbow. It feels like it is, but then we start flossing the nerves, and within literally kind of 20, 30 seconds of doing the motion, they're like, oh my God, my pain is gone. So it can be that last little key element of resolving some of those tricky cases.
Mm-hmm.
Yeah.
Wow.
Well, today's conversation has been a taster, and we'll catch up with you again later in the year.
Yes.
Which I'm actually looking forward to meeting you in person and then having another conversation with you as well. So, Aubrey, we really appreciate your time today. There's been a lot in today's conversation for therapists to think about, especially around how we do approach chronic pain in practice. Before we finish up, just another shout out. We'll be seeing you in Melbourne at the Massage and Myotherapy Australia conference. Therapists also have the opportunity to train with you in Melbourne, Brisbane, and Hobart in June.
Yes. Very excited to go to Hobart. My first time in Tasmania, so really looking forward to it there. Big shout out to all the therapists in Tasmania. Hopefully you'll come and learn some new techniques and help your clients.
Yeah, it's God's country down there.
I hope you get a little time to have a look around near Hobart, because it is beautiful. It is an absolutely stunning place.
Excellent.
Yeah.
Looking forward to
Good
it. Yeah,
beer
we're
as well.
actually a bit of a tour on as well, because my sister is coming over with me as well, and we're going to pop over to Sydney. We're going to go up to Cairns as well. So yeah, if people are around, keep an eye on our social media. Give us a shout out if we're in your area. Love to see you guys.
Nice.
You're going to have an amazing trip. I'm almost jealous.
Jackie is packing her bags. She's up for the journey, the road trip.
Do you need a personal assistant at the moment? Someone to do your things?
Just bring some extra heavy cases just in case, so I need somebody to carry them for me.
Exactly. Amazing.
Well, if you have enjoyed this episode, make sure you are following the Folding Towers podcast on your favorite listening app so that you don't ever miss an episode. And if you'd like to support the show, you can also buy us a coffee. The link is in the show notes. And it helps us to keep these conversations going for the profession with more excellent therapists, just like our conversation with Aubrey today.
Thank you so much for joining us, Aubrey. This has been amazing, honestly. None of the information you talked about today is really new to probably David as well as myself, but I feel like my brain is just so excited and it's like, oh, I need to go home and look this up and look that up and do this other thing. And yeah, so thank you so much for joining us.
Well, thank you both for having me on. I really enjoyed the conversation. Really appreciate you guys. Thank you.
We will catch you in another one.